Welcome to Parasitic Diseases. Today we're going to discuss Amoebiasis. This is a disease caused by Entamoeba histolytica. Like so many other parasitic infections, this infection has no borders. So this is called Parasites Without Borders. Perhaps we should rename this program Parasites Without Borders because indeed Amoebiasis is found throughout the world. Wherever you find people, you will find Entamoeba histolytica. In the early days of discovery, we had the advantage, at least, of having good microscopes and good cytological stains. So we could see things and correlate them with clinical conditions. And indeed, Schauden, who is given credit for establishing the morphology of Entamoeba histolytica, isolated from patients suffering from acute amoebic dysentery. So he was pretty sure that what he was looking at in the stool was the same organism that was causing the problems in those patients. Schauden described the amoeba of Entamoeba histolytica as a flaccid-looking cell with a round nucleus and a central karyosome, with inclusions that resembled, well, in this case, it turned out to be red blood cells. At the same time, Loesch in Germany also looked at exudates from patients suffering from diarrheal diseases, and instead of finding this organism, he found another organism, which was much larger, much more frothy in its cytoplasm. It had an eccentric karyosome, and it turned out not to be the causative agent for amoebic dysentery. And so it was named Entamoeba coli, an unfortunate name for this organism because there's a very important bacterial species. When you abbreviate that Escherichia coli and this Entamoeba coli on a report back from the laboratory, E. coli shows up in both cases. So whatever you do, spell it out so that there's no mistaking which E. coli we're talking about. This is non-pathogenic, and this is pathogenic. How do we know this is pathogenic? All we had to do was ask Lafleur. Lafleur actually described the pathology of this infection in patients suffering from acute amoebic dysentery and described this remarkably descriptive flask-shaped ulcer in which the amoebae themselves were found at the living edge. And as we'll see, this is an insidious infection that can actually result in the death of the patient. First, a little morphology just to reinforce what I just said. Here are two pictures taken, photomicrographs, I should say, of stool stained differently for various stages of protozoa. And in this case, we identify now the trophozoite and the cyst stage of Entamoeba histolytica. Here's that nucleus that I was describing before. Here are these same-sized inclusions that turn out to be red cells. And this is an ongoing infection in a patient that's exhibiting bloody stool, bloody diarrhea, which is the definition for dysentery. Shown over on this slide here is the resting stage of this parasite, the stage that allows it to go from patient to patient by simply exiting from one patient, surviving in the environment until such time as the fecal contamination of either food or water results in the ingestion of this stage, which then initiates the infection in another patient. It contains 4 nuclei, 2 of which are shown here. This is probably another one over here. And this large inclusion body, which turns out to be all of the stored ribosomes from this trophozoite stage, keeping it out of harm's way until this is re-ingested by another patient, in which time, well, we'll see what happens when I describe the life cycle, which is coming up next. So the infection is initiated by humans being exposed, and in this case, humans only. Notice there are no reservoir hosts shown for this parasite. Not that we couldn't infect some non-human primates with it. In fact, gorillas are susceptible to this infection, but they don't represent a threat to human populations for the most part, and therefore they are not included as a reservoir host. So one patient passing cysts allows water and food to become contaminated with feces, which is not uncommon in many places throughout the world. The cysts are ingested, and then for each cyst containing 4 nuclei, the 4 nuclei replicate once inside the cyst, and then out of the cyst bursts these 8 small trophozoites. And this all occurs in the large intestine. This organism, by the way, like Giardia, is an anaerobe. It immediately invades the tissues and begins the pathological process, which could result in a frank bloody diarrhea or dysentery. And this takes several weeks to develop, and it occurs in the transverse colon for the most part. To complete the life cycle, some of these trophozoites, which are eating away at living tissue inside the large intestine, round up and exit the lesions that they've created, entering the lumen of the large intestine, going to the descending colon, and then out in the feces, to now enter the environment, which allows, of course, for reinfection of another person. These cysts are long-lived. In sewage, they can last for up to months. In most situations, however, if the stool remains on the ground for any length of time, let's say 2 or 3 weeks, it's probable that the cysts will eventually die from lack of moisture. The pathological consequences are shown here. Mostly it's an intestinal infection, but not only. Sometimes the organisms can erode their way into the blood supply in the submucosa of the large intestine. They can enter the blood supply. They can be transferred to the liver, where they can initiate another form of the infection called extraintestinal amoebiasis. And if the patient is really unlucky, the trophozoites, instead of lodging in the liver, can travel to the brain, where they do the same things that they do in the liver, only in this case, it's usually with fatal consequences. How does this organism survive in an animal, namely us, with an extremely sophisticated immune system, which has many, many arms of it to bring to bear on infectious agents? And the answer is rather interesting. First of all, this organism can be grown in vitro. So what we see here are Chinese hamster ovary cells grown to confluence, and then the trophozoites are placed on top of them to show you the greed factor associated with Entamoeba histolytica in vitro, at least. These organisms are so voracious in their appetites, and I realize that's anthropomorphizing a little bit here, that they don't even finish ingesting and digesting one cell when they start the process of ingesting a second cell. That's best illustrated over here, where you see T for the trophozoite. This is the trophozoite tissue. This is epithelial cell number 1 in the process of being digested, and it's already in the process of ingesting epithelial cell number 2, and it hasn't even finished its dinner when it's asking for another meal. And these organisms can go on and on in the tissue culture until all the cells are gone. It is not unlike other infectious agents that require certain steps before they can actually start to ingest a cell, and that's best illustrated here. The Entamoeba histolytica requires galactose on the surface of the host cell in order for it to attach. Once it attaches to the surface of the host cell, it mediates a lot of changes. There's a signal transduction event that occurs which stimulates the production of non-lysosomal enzymes. That is to say, Entamoeba histolytica has no frank, definable lysosomes, and yet it's able to produce lysosomal enzymes. And it does so at the surface of contact between itself and the target cell. There's another thing that occurs when that event occurs, and that is that it stimulates the parasite to produce a pore-forming protein. And this pore-forming protein actually pokes a hole in the membrane of the host cell and kills it. So at the moment of attachment, the host cell is also killed and then ingested. And you can see an in vitro representation of what happens in the presence and absence of the galactose moiety that it uses to contact and to attach to the host cells. When you place in culture a lot of galactose, shown here, as compared to the control in which there is no galactose in the medium, and you do a cell sorting examination of the contents of this plate, you'll see lots of live amoebae. Lots of live amoebae over here. A portion of the cell population is still alive here, but a much larger proportion of the cells, let's say after 24 or 48 hours, are killed off by these parasites. If you were to flood the medium with galactose and prevent the attachment of amoebae to the live cells, most of the cells are spared and very few cells die as a result of exposure to just the presence of the amoeba itself. It requires more than that in order for the pathology to evolve. And this is the basis for that. Now, Dr. Daniel Griffin is going to give a clinical vignette illustrating further the pathogenesis of this infection.
A 33-year-old male of Chinese descent living in Chinatown, New York City, comes into the clinic to be seen with several months of on and off watery diarrhea. He also reports headaches, but no other constitutional symptoms. He has tried reflexology and chiropractic therapy, but none of this has helped. He is HIV-1 positive with a CD4 count of 685. His viral load is not detectable. He was diagnosed with HIV about 2 years before, and he reports a large number of male and female sexual partners. He says greater than 50. He is on a highly active antiretroviral therapy, or I should say he is being prescribed such. It's not clear that he's taking it, but with the viral load not detectable, would be reasonable to think he is compliant. He also reports syphilis, treated 6 years before. He reports being bisexual with these multiple partners and engaging in many styles of sexual activity. He lives in Chinatown, but travels to Chile, to Santiago, and other areas outside the city, and has done this several months prior to the onset of the diarrhea. And he does this for sexual opportunities, sort of sexual tourism. Now, we're going to be talking about the two main types of clinical disease, intestinal amoebiasis and extraintestinal amoebiasis. Now, intestinal amoebiasis, most exposed individuals are asymptomatic, but a certain number will go on to experience clinical disease or become chronic carriers. The most common clinical manifestation is diarrhea, lasting more than a few days, and in some cases for weeks, months, or even years if not treated appropriately. And I italicize this because I think this is important. Although a large number of patients do not report blood or excess mucus in their stools, almost all the stools are heme positive if you test them. People often think of amoebiasis as dysentery and they're waiting for a history with blood. And often you will see that, but not always. But if you do testing, you'll actually be able to detect the blood. Now, in the chronic condition, Amoeboma, or a large granuloma consisting of eosinophils, amoeba, and necrotic colonic tissue, these can develop, and they present as palpable masses. Unfortunately, amoebomas are often misdiagnosed on barium enema as malignancies. Now, what about extraintestinal amoebiasis? The amoeba can erode through the wall of the large intestine into the circulation, and the submucosa can be breached. In this case, the parasites are thought to enter mainly through the portal circulation and disseminate throughout the body. The most common extraintestinal site is the liver. Occasionally, they present as a medical emergency. Now, invasion of the liver tissue may occur after symptomatic intestinal amoebiasis or in cases where the colonic infection is asymptomatic. And nearly half of all the patients with amoebic liver abscesses do not have a history suggestive of amoebic colitis. Most patients with hepatic amoebiasis have involvement of the right hepatic lobe, but the left lobe can also be infected, and the enlargement and tenderness can be central or even left-sided. The lungs are the next most common extraintestinal sites of infection. People often just think of the liver, but the lung can be involved as well. There can be direct extension to the right pleural space, And the lung is the most common form of intrathoracic amoebiasis. But hematogenous spread, so spread through the blood, may cause metastatic spread to other portions of the lung, to the pleura, as well as the brain. Amoebic pericarditis, so the amoeba infecting the area around the heart, can occur. The major pleural pulmonary manifestations can include effusion, pleurisy, empyema, and then even lung abscess. As mentioned, spread to the brain can occur. Rarely, you can get cerebral amoebiasis. In this clinical context, the onset is usually abrupt and is associated with very high mortality rates. Now, this is gross pathology of the large intestine with disease due to Entamoeba histolytica. Here is the classic flask-shaped ulcer due to infection with Entamoeba histolytica. And this is a characteristic feature, not unique, but the trophozoites of Entamoeba histolytica can have RBCs in their cytoplasm. And these are unfortunately multiple abscesses in the liver from a fatal case of Entamoeba histolytica. But what about diagnosis? Now I'm going to break this down. Diagnosis of intestinal. As I mentioned, stool testing for heme is positive in almost all cases of intestinal amoebiasis, but stool tests for leukocytes tend to be negative. The amoeba seems to have the ability to destroy or ingest leukocytes, despite the fact that this is an invasive disease and one would normally expect leukocytes or white blood cells. Definitive diagnosis depends upon detection of antigens in the stool, nucleic acid amplification testing in the stool, or microscopy coupled with species identification, because just morphologically you can't look and tell that this is the pathological species versus one of the benign lookalikes. Now, since infection with Entamoeba histolytica invariably leads to long-lasting antibody production, a positive antibody test can be difficult to interpret. Now, serological testing will become positive even intestinal amoebiasis about a week after the onset of symptoms, will remain positive for years. Now, what about the diagnosis of extraintestinal? Now, intestinal and extraintestinal amoebiasis do not usually occur simultaneously. So stool testing is usually negative in the setting of extraintestinal amoebiasis. Serology, usually positive in cases of extraintestinal amoebiasis, but may be negative during these first 7 days. And as mentioned, serology is not going to tell you whether or not this is occurring right now or may have happened years ago. Imaging tests play a critical role in the diagnosis of extraintestinal amoebiasis. Radiography of the abdomen may show enlargement of the liver and a fixed raised diaphragm. A radionuclide or CT scan often reveals the abscess. It may also show additional abscesses. On ultrasound, an amoebic liver abscess usually appears as a round hypodense area that is contiguous to the liver capsule, usually without significant wall echoes. Now, if the diagnosis is still in doubt after serological testing and imaging, the cyst can be aspirated. Now, the obtained fluid is often described as an anchovy paste, but often it can be clear or even yellow in culture. Now, the amoebic forms are rarely present in this fluid because the amoeba are going to be, you can think of this as like some of our other infections, they're not going to be floating around. They're going to actually be in the tissue at the edge. So unless someone is actually able to get a biopsy of the edge of this lesion, they're not going to detect the amoeboid forms. So antigen testing, nucleic acid amplification testing are going to be helpful in confirming the diagnosis. Abscesses also may be secondarily infected with bacteria, so sending the fluid for bacterial culture is recommended. Now, what about diagnoses? As we mentioned, you can identify the trophozoites or cysts in the feces, and here, showing a trophozoite, and here we've got a cyst. The two nuclei are shown by arrows. Morphologically, you can't tell the pathologic from the non-pathologic variants. Even when you see RBCs, if you look at some of the early papers, even some of the non-pathogenic amoeba can actually ingest RBCs. When you see a large load in the right clinical context, that would argue. But ideally, you want to be able to, not morphologically, but with a more specific test, distinguish pathogenic from non-pathogenic. Treatment is going to be based upon whether we're dealing with intestinal or non-intestinal or extraintestinal. Now, treatment of intestinal. All forms of symptomatic amoebiasis are considered invasive, and treatment is recommended. But I'm gonna mention right up front before we even tell you which drugs we're going to use, is since these drugs that we're going to use do not target the cyst stage, we always recommend, and I'm not sure everyone follows this advice, but a second intraluminal agent should be used to target the intraluminal cyst. So, primary agent for treatment, metronidazole, 500 milligrams 3 times a day for 10 days. Usual caveats about not mixing this with your alcohol, as you may have this disulfiram type reaction where you feel like you've got the taste of formaldehyde. You do have alternatives to nitazole, nitazoxamide, but then don't forget that luminal agent. You want to get rid of these cysts. Iodoquinol, paromomycin, diloxanide. So we have some options there. Now, what about extraintestinal? Again, got to repeat that since these drugs are not going to target the cyst stage, and even though these people do not necessarily have intestinal symptoms, they often will still have cysts, and they'll still be shedding cysts in their stool. So go ahead, use the metronidazole, 500 milligrams 3 times a day for 10 days, or one of the alternatives, just like we would for the intestinal. But again, look at treating with luminal agents. Now our patient, how did our patient do? Acid-fast stains and Giardia antigen stool testing were negative for Cryptosporidium, Cyclospora, Isospora. Bacterial cultures were negative. A stool guaiac test was positive, but the stool leukocyte test was negative. The patient had a stool over in parasites, which were positive for trophozoites, and the Entamoeba histolytica, which was shown to have ingested erythrocytes, and the species was confirmed by NAT testing. The patient was treated with metronidazole, 500 milligrams, 3 times a day for 10 days, followed by the luminal agent paromomycin, 1,000 milligrams, 3 times a day for 7 days. He did well.
Prevention and control. It's pretty standard to control fecal contamination of an environment, bury it, or treat it. And this has proven very effective in everywhere where sanitary disposal of feces exists. Now, I must tell you that this infection is being brought in all the time from places around the world to places like New York and Paris and London and Moscow. You go to the larger cities of the world, and there's a large influx of people always moving into these areas. And we don't know where they come from, and they get jobs related to becoming the dean of a medical school all the way down to a waiter in a restaurant. Now, the dean of the medical school might not be a problem, but if he's or she is a waiter in a restaurant and they're harboring Entamoeba histolytica, and they have moved from the acute phase of their infection to the chronic phase, which could result in them becoming a carrier rather than a sufferer, they have the option of spreading this infection from person to person by unsanitary behavior. So I just wanted to add that as a control measure because it's obvious that a lot of these infections are acquired during those kinds of situations. That is, eating out at least once a week. We've discussed Entamoeba histolytica at least 3 times on This Week in Parasitism. Again, you can access that on microbe.tv/twip, and we hope you enjoy those sessions and listen to them. We've enjoyed presenting this to you. So the next time we talk, we'll talk about Balantidium coli, the only ciliate to infect humans. Thanks for listening.